Lindsey, guys. Lindsey Peters. She's one of our nurse practitioners for our neurology department, and she used to do my job. So it's really cool to have her here and see her. And she has a great amount of information for you about lifestyle changes post-stroke. So welcome, Lindsey. Give her a warm introduction. I'll let her take over.
This has been this foundation is just so near and dear to me. So I'm really happy to see you all. So thanks for being here. All right, so this is kind of a broad topic. I guess I'll just say first off, I don't have anything to disclose. I'm here to be here. So this is kind of a broad topic. So I tried to just kind of do a broad overview, and then feel free to ask questions. And then in the end, if you've got more specifics, there's a lot. Oh, there we go. This is a very broad topic, so I know that, and feel free to ask questions, and if you want more specifics on things, but just try to cast a wide net. So these are the main things we're going to talk about today. So life after stroke. So the first thing, kind of what we work on really hard in the hospital setting, is secondary prevention. So you've had the first stroke, the second, hopefully not, or so. And so how do we prevent further strokes? So that's kind of the medicine aspect. Then we're going to talk about potential complications, things that unfortunately just kind of are can happen after having a stroke, and then resources. All right, so first, just to kind of review over the different stroke types. So the first one I put is a transient ischemic attack. So it's a temporary blockage of the vessel. There isn't any permanent tissue damage. So usually the symptoms last usually about 24 hours and less than 24 hours or so, and then resolve. So but the key with a TIA is that there isn't any permanent tissue damage. Then we have the acute ischemic stroke. So that's where the vessel is blocked and there's actually some tissue damage with that. So there's a couple types. So this is called an embolic stroke, meaning the clot came from somewhere else and blocked the vessel. Oftentimes the heart is the culprit. There's also kind of atherosclerosis. You can see this yellow here, this kind of narrowing of the vessel. So eventually over time, the plaque kind of thins and then you have a blockage of the vessel that way. The other is an intercerebral hemorrhage. So you have, I'm in your way. Sorry, I just realized that. You have a rupture of that vessel. You have bleeding into that tissue that causes the tissue to die that way. And then you may have a problem with the actual vessel itself called a aneurysm. It's just kind of a weakening of the vessel and it ruptures. So when we're talking about stroke, the majority are ischemic strokes. So it's about 88% of strokes fall into this category. About 10% are hemorrhagic strokes. So usually from high blood pressure causes that little artery to rupture. And then only about 2% are due to an aneurysm that's ruptured. Yes.
What would I consider I had a punching bleed? So where is that ending up?
So you would be right here in this category. So one of the arteries in the pons, in the back, kind of in the brainstem, ruptured. And most likely it's from high blood pressure. So those little vessels, which we'll talk about why they're so sensitive to a lot of these lifestyle things. All right, so within secondary prevention, preventing that second stroke, we'll talk about non-modifiable risk factors, things that unfortunately we just can't do anything about, the risk factors that you can manage, and then lifestyle changes. Okay, so the non-modifiable risk factors, these are things that unfortunately, as much as we would love the fountain of youth, we just, increasing age, just, over time, those vessels just become kind of thicker and hardened. Generally, most strokes occur over the age of 65, the majority of them, but we definitely see strokes that happen in young cooks all the time. So gender, typically women, more women have strokes. Generally they live longer, but also there's a lot of pregnancies associated with a lot of strokes during that period, just with the hormones and a lot of the changes there. Race, typically African Americans and Hispanics have more strokes. Family and personal history, so genetics, there are certain genetic disorders that make you more prone to having a stroke. Things like sickle cell anemia, things that just are out of your control. Having cancer makes your blood a little bit stickier. And then if you've had a prior stroke, TIA, or heart attack, unfortunately, your risk is just higher just because you have that in your history. So all these things, unfortunately, we can't do a lot about. So we'll talk about all the ways that we can make changes. So these are all the risk factors you are in your control to manage. So we've got hypertension or high blood pressure, and we'll go through and talk about each of these individually. High cholesterol or hyperlipidemia, diabetes, smoking, carotid or other artery disease, atrial fibrillation and heart disease, sleep apnea, excessive alcohol use, illegal or illicit drug use, physical inactivity, obesity, and being overweight. So really, there's a lot of things that are in our control that we can try and work on to prevent future strokes. So actually, and when it comes down to, this is taken from the secondary prevention guidelines. So the overwhelming majority of strokes can be prevented through blood pressure control, a healthy diet, regular physical activity, and smoking cessation. So globally, worldwide, about 91% of the global burden of stroke was due to modifiable risk factors. So that's a lot of things that we can work on. And that's why I'm glad you guys are all here. So the first thing, hypertension, high blood pressure. It is the #1 cause of stroke. And so the way it causes stroke is, here's a nice healthy vessel. You've got a nice open wide artery. Over time, the high blood pressure just kind of causes inflammation on that vessel, and it narrows it. So you have an increasingly thick wall, and it reduces the size of that vessel. So it makes it more difficult for your red blood cells and your platelets and things to travel freely through that vessel. And that happens over time. So for most people, the goal after a stroke is to keep their blood pressure less than 130/80. We'll talk about a little bit later some other circumstances that might change, but for most people, that's the goal for blood pressure. The treatment, so we're going to talk a lot about diet and exercise. So diet, especially decreasing your salt intake, because with a lot of salt intake, that pulls fluid into the artery and it increases your blood pressure. Exercise, and there's always medications. Pretty much you'll get put on a medication as soon as you leave the hospital. There's lots of different types. Some are diuretics, water pills where you're kind of removing the fluid. Some work on your kidneys to kind of help dilate your blood vessels, and some work on the actual kind of calcium channel within the vessel. The next one, hyperlipidemia or high cholesterol. So that's excess lipids within the blood vessels. As you can see here, this is a nice healthy vessel. And then these red little dots are the red blood vessels. And this big kind of blob here, this yellow, that's the cholesterol. And over time, it just kind of builds up in the vessel. Cholesterol is made by the body, but actually 80% is made by your liver. And then we get the remainder, about 20%, from the foods that we eat. And so the role, so there are good fats and things like that. And so they're important for producing hormones and digestion. But we're going to talk primarily about the two primary, they're lipoproteins. So the low density and the high density. So you may hear about this LDL, the low density. Those are the bad cholesterol because they increase the plaque formation. So you can see this guy here. He's dumping he's the LDL guy. He's dumping a bunch of plaque into the vessel. But then we have the HDL, the high density, and that helps absorb the bad cholesterol and takes it back to the liver to where it can be kind of metabolized and get rid of. So this guy's working hard at removing some of that plaque, but unfortunately it doesn't do all of it. So the goals with this, we want that LDL, or the least desirable or the low density lipoprotein, we want that less than 70 after you've had a stroke. And then the HDL, we want that as high as possible, because again, that's going to help offset that bad cholesterol, I guess the less desirable. And so we want that greater than 40. So a lot of times, again, diet and exercise is really key there. Things like decreasing low-fat diets and watching the types of kind of saturated fats and things like that you consume. But there's also medication. So the most classic one is statins. That's the most effective drug class. And so Lipitor is a pretty common, atorvastatin is one we use most commonly. And then there are a lot of people that unfortunately it can cause muscle weakness and things like that and muscle pains. So there are alternatives that we can use. One that's becoming more popular, I guess, is this type of drug class, the PCSK9 inhibitors. And there's definitely a family component to high cholesterol. And so a lot of times if people just aren't, the medications that we're prescribing really aren't that effective, they need this, and it's an injection that they'll get. All right, so the next one is diabetes. So the majority, 91%, of diabetics have type 2. And so the type 1 diabetics, it's an autoimmune, they're born with it, and it's the body's response. But type 2 is just kind of over time, it's a progressive impairment of insulin sensitivity. So your body just doesn't work as well. That insulin doesn't work as well over time. And then your pancreas doesn't secrete as much insulin over time. And so it also alters how you kind of break down fat. But the good news is that remission, or kind of being free from type 2 diabetes, can be cured or just kind of at bay by, for most people, by weight loss. So when we do have diabetes, our goal that we tell folks for most people is to have a hemoglobin A1C, which is your average blood sugar over a 3-month period. We want that number to be less than 7. And things that you can do to work to get there and to manage your diabetes are diet. And a lot of that is monitoring those carbohydrates, which end up breaking down as sugars. And so the best thing for your body is to have kind of a consistent level. So you want to make sure that you're not having a lot of sugar intake and then decreased sugar intake. And then a lot, because that's hard for your body to regulate. So kind of a consistent diet with that. Exercise, insulin, sometimes like insulin injections. And then there are really a lot of remarkable new medications that have been developed for diabetes, which are great. So a lot of oral medications, and a lot of them have the benefit of weight loss. So, which is really exciting. So next is smoking. Smoking is probably the #1 worst thing for your blood vessels. So the way it works to cause stroke is that it those chemicals, the nicotine, cause a constant inflammation and swelling of those blood vessels, the blood vessel lining, and that also works to narrow that artery. So you're reducing blood flow, but also those chemicals make your body more prone to having clots. So not only is the artery narrowed, but you're more prone to clots, and then you're more likely to have a stroke there. So additionally, the effects on the lungs, it reduces your oxygen that gets to your tissue. So less oxygen that gets to the brain as well. And just that risk factor alone doubles your risk of having a stroke. It's probably the #1 cause of aneurysm development too, which is that weakening of the artery. And so the treatment cessation, which is so much easier said than done. I mean, it is a very challenging thing because it is an addiction. So we'll talk about later how things that have been proven to help kick the habit. So all of these things, the things we've just talked about so far, all lead up to this word that you've all may have heard called atherosclerosis. So it's basically just a narrowing and stiffening of arteries from plaque that has built up along your artery wall. So it's kind of within that wall. And so over time, it's narrowed. As you can see here, it just slowly starts building up to become more and more. But the problem is that those plaque buildup, they rupture. And anytime that rupture happens, your body sends, oh, hey, something's happened. I need to send platelets to that area to seal that area off. And then you have a clot that forms. And if it becomes large enough, those platelets grab their friends and they become, a nice big bond there, it'll seal off that artery altogether. And so that's how you get strokes deep in the center of your brain, because those arteries were already small to begin with. And so now over time, they've narrowed, and then you have an insult to that vessel. And so you get a clot that forms there. So generally, what we'll treat those with are antiplatelet medications, because we want those platelets to be real slick so that they slide easily through those small those small arteries and that they don't stick together. So generally, right in that first period after your stroke, we may do extra kind of antiplatelets. 2 of them, common ones, are aspirin and Plavix. If you have a stent, there may be also another medication called FIBRILLATION, but generally, then after that, most people are on aspirin or just one, like Plavix alone. So, but I will say, you have noticed more and more people are what we say non-responders to Plavix. It's just a kind of a genetic piece. So that's becoming more and more prevalent that we're seeing. So. All right, so over time, so we kind of, atherosclerosis is pretty much, it affects those small arteries the most, but over time it also can impair the larger arteries. So the carotid arteries are the big pipes in your neck, and they kind of narrow as they get farther up into the head. And for these patients, because it is such a large artery and it provides the whole flow to that whole hemisphere, sometimes a little bit higher blood pressure is needed if it's really significantly narrowed. So generally for these patients, it's okay to go up to less than 140. And then after you've had a stroke because of that, generally we'll keep you on those 2 antiplatelet medications for about 3 months. But if it becomes to the point that it's so narrow, generally once you get to at least 70%, we kind of start talking about how can we, some sort of intervention, additional intervention that we can do besides medication to help prevent that. And so the 2 most common are what's called a carotid endarterectomy. And that's where a surgeon, a vascular surgeon or a neurosurgeon will go and they'll make an incision in the neck and they'll actually pull out that piece of plaque. And so, and then they'll sew that back up. And so you have a nice open vessel there. Generally, that's kind of the first line treatment. Sometimes there's just maybe somebody's anatomy, or it needs to be an emergency, or there's a lot of factors in that decision, but sometimes they might put a carotid artery stent. And so this is the same type of mechanism that you have when you have a heart attack and you have a stent in your heart. It's the same concept. You have a big stent, they take a balloon up through that artery, inflate the balloon to push that plaque, to push that plaque down and open that vessel as they can, and then they put that stent there. The difference with our neurostents is that you need to be on an antiplatelet with it. So the heart stents, some of them have medications that are impregnated in them, and so you don't have to, but these definitely you have to be on an antiplatelet. And so there's a bleeding risk too. So lots of things to consider, but those are kind of the main treatment courses if you need an intervention and medication isn't working very well. There's a new one called TCAR. I can't remember off the top of my head what it stands for, but basically our vascular surgeons do it. And again, it's directly accessing that artery, and they put the stent directly in that artery right from the neck, and they have reverse flow, so there's less chance of clots going up farther up into the head and having a stroke because of the procedure. So there's needs to be more information to see how that compares to these others. All right, atrial fibrillation and heart disease. So heart disease is kind of a broad term, and it includes a lot of things, including cardiac arrhythmias like atrial fibrillation, atherosclerosis disease like the heart attacks where you have stents, heart valve disease, sometimes like aortic stenosis, things where that vessel's just so narrowed, you're not getting a lot of good blood flow through it. Heart failure, where the heart's just not pumping as well as it should. And then heart infections, which we'll talk a little bit about. All that is kind of a broad term for heart disease, and all of those can lead to having a stroke. Atrial fibrillation is probably the #1 cause of a cardiac of an embolism from the heart that goes up to the brain. And so basically what atrial fibrillation is, your heart it pumps by electrical activity. And so the first impulse starts at the top chamber of your heart called the atrium, and it sends an electrical activity down through your heart and then tells those chambers to squeeze, to pump. When you have atrial fibrillation, it's completely disorganized. So instead of having that initial impulse from a nice, same one spot, it comes from multiple areas within that top chamber. And so your heart is kind of like, I don't know what to do, where to send the further signals. So it leads to irregular contraction of that heart. And so when you have a irregular contraction, blood kind of pools there and sits there. And when blood is pooling or sitting there, it forms a clot. So the next time you get a good squeeze, you squeeze a clot and it goes up into the brain. So there are lots of different treatments options, and that really just depends on you, what's most effective for you. The first is generally medication. And so we want your blood nice and thin. So if that happens, you're not forming those clots in that top chamber. So common medications are warfarin or Coumadin, where you have your INR, your blood levels monitored, or Eliquis and Xarelto, which are medications that there isn't lab values to monitor. We just know it is effective. And then some just antiarrhythmic medications to kind of help with that electrical activity. Cardioversion, which is where they kind of give you some sedation medication. They kind of give you a little jolt to the heart and kind of try to shock you out of that rhythm. Ablation, where they go in and they kind of burn those areas so that the electrical activity is trying to come from one spot. And then a lot of people, are fall risks, or there's some reason, or they just don't tolerate the blood thinner. Maybe they have gastrointestinal bleeding or things. And so for those patients, we generally refer them for what's called a left atrial appendage closure device. That the brand name is the Watchman device. And so there's a little kind of plug that they put right here that kind of helps seal off and prevents atrial fibrillation. All right, so the next one, obstructive sleep apnea. So this one is, I wouldn't say controversial, but the data doesn't support it as much, that we don't screen as often as we probably should for it. But this particular obstructive sleep apnea is where you have, when you're sleeping, your airway is nice and open. You take breaths and your airway is open here. But with obstructive sleep apnea, sometimes during the night, your tongue kind of weighs there and it falls back and it occludes your airway. So you have periods of time during the night where you stop breathing, you're apneic. And then if it's so severe enough, your oxygen levels drop. And so the challenge with that is that causes a lot of stress to your heart when this happens, because it's not getting the oxygen that it needs. Your heart's so your blood pressure's up at night, having increased carbon dioxide levels makes you more prone to having clots. So there's definitely risks with this in causing strokes. And so particular things are sometimes, if you have your nightcap, your alcoholic drink before you go to bed, that can force sedation medications to help you fall asleep. Those can relax those muscles and make your tongue more prone to collapsing that airway. Also smoking, just with a lot of that cigarette smoking, that increases the airway edema or the swelling. And so again, that's another way that it blocks your airway. And then just having extra weight, around that neck. So when you lay down, that extra fat kind of relaxes and blocks that airway. So, and then it happens with a lot of our stroke patients. So about 38 to 40% of patients have sleep apnea. But the best way to diagnose it is, the fancy term is polysomnography. So when you're sleeping, they hook you up with a bunch of leads and they watch you sleep and monitor your oxygen levels to see if how many times you stop breathing through the night and if your oxygen level drops. So treatments, they're continuous positive airway pressure or CPAP machine. There's been lots of advancements with that. So that's the mask on your face that's connected to a hose. Sometimes they'll have a nasal cannula or in your nose where there'll be a high flow there. So there's various methods for that. Oral appliances, something that help keeps your mouth open. Surgery sometimes to open up that airway, nerve stimulators, and then just weight loss too to help with that. And I will tell you, my dad, I was on his case many times when we were on vacation and said, I'm not going on vacation with you anymore because you snore so loudly and stop breathing and I can't handle it. So he got his CPAP machine and, you know, he feels so much better. So I will say, like, if you can get over the hump of the apparatus and whatever works best for you, if you can get over that, it's once you start getting more rest and you get that oxygen, you start feeling better during the day and you're not so sleepy, and it really does, it is a game changer. So excessive alcohol intake. So I will say on this one, it's a little, I went through the literature just to make sure before I presented this, that it's a little not controversial, but there's always, you know, that thought of, well, red wine is good, or there's, you know, alcohol intake isn't so bad. But the mechanism actually for causing stroke is that high blood pressure, because again, it's a diuretic and has the diuretic properties, and it increases blood pressure that way, but also causes damage to the vessel wall. More so it leads to excessive calories, because there's kind of empty calories, the more, you know, and the sugary carbohydrates with what you consume, but then also the additional eating around that. So that's also how it leads to stroke. And also it makes your blood a little thinner, so you're more likely to have a hemorrhagic stroke where you rupture that vessel and you have bleeding because your blood's a little thinner. However, what the studies have shown is that it's a J-shaped curve relationship between alcohol use and stroke. So what that means is when they looked at the studies, people that drank just a little bit actually seemed to do a little bit better than people who didn't drink at all. But the more you drank, the more alcohol intake you had, the increased risk for stroke. So I didn't say I'm not advocating that you start drinking alcohol if you haven't already, but there are some protection in just kind of light to moderate alcohol use. And the reason is it increases your HDL, that good cholesterol. It decreases your kind of platelet activity or aggregation. So there's decreased risk of clots. It helps insulin work a little bit better. So there are some protective capabilities, but we know that the more you drink, the actually increased risk of stroke you have. We'll talk more about that a little bit later, but recreational drug use. So these are things like methamphetamines, crack, cocaine, anything that's not prescribed or could be considered a street drug. And so the mechanism that causes stroke with these is generally you have surges in blood pressure. So that drug just, especially, you know, cocaine and thing, it causes significant high blood pressure and it causes those vessels to spasm. And so when they spasm, they completely clamp down and you don't get blood flow past that point. Also, if it's IV drug use, a lot of times the needles are dirty, or there's, you know, you get a skin bacteria, just healthy bacteria from your skin gets into your bloodstream that way, and it goes in and attaches to those heart valves. And so you've got growth on those heart valves called endocarditis. And so the valve, every time it opens and closes, you release little pieces of bacteria up into your brain, and you can have a stroke that way. So, but also there is actually, you know, with all of the latest legalization of marijuana use, it has different mechanisms. There's still a lot of research going on. However, we are seeing an increased incidence of stroke in young folks between 18 and 44 with marijuana use. So to be continued. So the best thing is just abstinence for that. All right, so physical inactivity. So generally sitting for more than 4 hours a day. There's a lot of benefits of exercise. So it works on a lot of different mechanisms. So it improves the vessel wall function. It increases your HDL, that good cholesterol. It helps with glucose regulation. It reduces platelet activity, so forming clots. And so all of those things will help you control or get off medications for blood pressure, diabetes, and hyperlipidemia, which you guys all did a great job of doing just before I got here. All right, so kind of obesity, that kind of goes hand in hand. So about 30% of adults in the US have obesity. And just that alone increases your risk of having a stroke by 50 to 100% solely because of all the risk factors that come with obesity. So, and it's overwhelming. I mean, it's overwhelming for a lot of people, and it's hard to do. But even just 5 to 10% of a weight reduction can have a significant impact on your cardiovascular health. So there's lots of different things out there, behavioral counseling, medications. There's Ozempic has been in the news a lot with a lot of, celebrities trying to get access to it because the weight loss there. So there's a lot of things on the horizon. And so it's definitely a complex medical issue for sure. And then there's the bariatric surgeries. All right, so now we're going to talk about the lifestyle changes, things that you can do to how you can impact a lot of these diseases. So we'll talk about diet, exercise and activity, how to avoid tobacco use, kind of what the recommendations are regarding alcohol, and then medications. So diet, the most two common that you'll hear about are the Mediterranean diet. That one focuses a lot on olive oil. There's a use of that, and oil from the good oils from tree nuts. And then there's a lot of fish too with that one. And that one includes a kind of moderation of wine. So whole grains and milk and dairy. So that's a very common one. And then the DASH diet. So that stands for dietary approaches to stop hypertension. So the focus of that diet, same kind of things, your fruits and vegetables, legumes, whole grains, fat-free or low dairy, but also salt. That's kind of a key with that one, is decrease salt intake, and then reducing red and processed meats. Your processed meats are things like deli meats, and then limiting saturated fats and cholesterol. And then the heart healthy is just, again, emphasizing fruits and vegetables, lean vegetables and animal protein, and then again minimizing those red meats and processed meats, because that's where we get a lot of the LDL. The animal products have that kind of that less desirable fat there, and then sweetened beverages and carbohydrates, kind of your empty calories. So exercise and activity, what's recommended is doing at least doing 40-minute sessions 3 to 4 times a week, or an average of about 150 minutes a week of vigorous aerobic activity. So really what that means is, do you break a sweat and or get your heart rate up? But really, once you've had a stroke, things change, and the way what you can endure changes. So it's really important that, you guys are all in the right spot doing modified things that work for you, but really it's kind of increasing your endurance and just being active. So tobacco use, there's a lot of different things, intensive counseling. Usually what's most effective is kind of a combination approach. So kind of the counseling, maybe plus medications. Medications usually include some sort of nicotine replacement, whether you have the patch, the lozenge, or gum. Wellbutrin, bupropion, that's also, it's kind of an off-label or atypical antidepressant that is used. And then Chantix, that's another common medication. So, but just stopping smoking actually increases your life expectancy by about 5 years. But also the other piece that's important too is environmental exposures. Let's say you live with a smoker, you don't smoke yourself. That also has all of the same risks associated. And so that can, just by being in the presence of a smoker and being exposed to that smoke, can increase your stroke risk by about 45%. So it's a good thing to just everyone you live in around not smoke. All right, so the limit on your alcohol intake. So again, there are a little bit of, some good properties associated with alcohol. In moderation, has kind of with everything. So the American Stroke Association says that for women, because we metabolize it slower, having 1 or less drinks a day is okay. For men, 2 or less, because they can metabolize a little bit faster, is okay. And so what's considered a drink, sometimes our portions are a little bit larger than they probably should be, but is 1 12-ounce beer, a 5-ounce glass of wine, 8-ounce malt liquor, or a shot, a 1.5 ounce of 80 proof liquor. So medication adherence, that's always a challenge, right? So making, especially with those twice-a-day medications, you know, making sure you get them in, you're out, you don't have you're out and about, maybe you miss meds. So that can be really harmful too, to kind of worsening disease processes. So anything you can do to kind of promote or increase your actual taking of those medications is great. So some suggestions, obviously the little pill containers with the Monday through Sunday on there, and then you can kind of line them up each week and you can see, oh, if I took it today or not. Setting alarm reminders, writing it down. I love checking things off my to-do list. So sometimes if you could do that to say you've taken your medications. And then some pharmacies will give you a little pill packet. So you know that you've got all your pills in one little sealed package there. So if you take that, you've got them all. All right, so we'll just kind of glaze over a little, just kind of briefly over some complications after stroke. So those are all the things that we can do to prevent future strokes, but now these are just unfortunately some things that can happen just to be aware of. So pneumonia, so generally it's due to from immobility, from not being up and about as much, for kind of laying around more, not being able to clear your lungs. Sometimes just the muscles have been affected, so you have more of a weakened cough and you can't quite clear those secretions as well. And a lot of times dysphagia, so the difficulty swallowing is a common thing after stroke, and so you can't quite clear those secretions and food and liquids from going into your lungs, so you can get some kind of seepage into your lungs that way. And so some ways to kind of prevent that: being active. Sometimes if you held on to your what's called an incentive spirometer, that's that funny little kind of large straw looking thing that helps promote deep breathing. So, or you can even just do deep breathing exercises on your own. And then proper body mechanics. So making sure when if you are eating and drinking, that you're sitting upright, that you're not laying down right afterwards, things that can help gravity and promote getting things down the right pipe. And then basically what pneumonia, just kind of a persistent cough. A lot of times it's productive, meaning you're coughing something up, and it's usually for a longer period, a couple weeks or so. So generally it may require a chest x-ray or just starting some antibiotics. Urinary tract infections. So very commonly what we see in the hospital setting is that folks have patients difficulty with their bowels and bladder. So they have incontinence, or they're not quite sure when they don't know when they need to go, or they retain, or there's just a lot of those signals that tell the bowels and the bladder to work have kind of been altered a bit. So especially when it comes to urinary incontinence, in the beginning, about 40 to 50% have that during their hospital stay. By the time they leave in the hospital with us, only about 25%. And then some will continue, about 15% will continue to have issues with incontinence at about the year mark. So just kind of symptoms to be aware, sometimes just kind of burning with urination, increased frequency, foul smelling urine, you can't quite empty, feeling like you're not emptying your bladder completely, and then treating with antibiotics. Seizures. So you've had an insult, we've had strokes, you've had an insult to the brain. So you are more susceptible to having altered electrical activity. So it's the most common cause of stroke in older folks. It's kind of a broad range, 2 to 23%. It's generally on the lower end. We'll have a stroke within we'll have a seizure within the first few days of their stroke. And then 3 to 67%, kind of again a broad range there. We'll have a seizure later on. And if there's already pre-existing dementia, that will increase the risk even more. And so, but typically we don't treat it prophylactically, meaning we won't put you on an anti-seizure medication just to prevent it, because there can be complications with those medications. So if it happens, then generally we'll put you on an anti-seizure medication. So, and it's more common with a ruptured aneurysms, because that is really irritating to the brain where that blood is located. Depression is also a very common thing after stroke. So that affects about 1/3 to 2/3 of patients. And it's associated with increased mortality and decreased functional outcomes. So, you know, if you just don't feel good and you just don't, you lost your motivation and things like that, of course, you're not going to want to participate in activities and moving around as much. So you might not regain as much motility as you could. Often there's anxiety associated with that. And so the best treatment they found is just physical activity. So there's a lot of neurotransmitters, different things that are promoted through exercise and activity, and especially group therapy, group exercise, just like you guys do here. So that's the best way to ward off depression. And a lot of times medications are needed, and it's a perfectly fine thing. And we do that actually quite a bit too. So whatever will get you motivated to kind of get back in life and find pleasure and to get moving. Bed sores a lot of times, and skin breakdown, just because a lot of times, you know, there's decreased movement to extremities. So they're just more prone to not moving as much and kind of sitting. There's decreased circulation just given age. And then sometimes when you have that incontinence, there's extra moisture there that promotes bacteria. So there's different stages. So in the beginning, it will start off as kind of reddened. And over time, the breakdown just becomes deeper and deeper. And so it's really concerning when it gets down to the bone. So those types of things, we have to get our plastic surgeons involved to kind of do some skin grafting and things like that. So it can be pretty serious and definitely a risk for infection. So it can be a pretty serious thing. So the ways to prevent that: good hygiene, regular turning, good nutrition so that your body repairs that tissue, keeping hydrated, and then minimizing kind of that friction or kind of irritation to the skin. Spasticity and limb contractures. So about 60% of survivors have to deal with this, unfortunately, and the wrist is the most common location. So, and then if elbows are more, excuse me, are more associated with that spasticity or the stiffness of those muscles. So, encouraging kind of daily stretching of those affected limbs. And then, but definitely I would encourage, you can cause more injuries. So definitely work with your therapist to figure out what's the best way to do that. And if families can help and helping, you know, kind of increasing their range of motion. And then it looks like the literature is kind of mixed on whether kind of resting hand splints kind of work to help keep those muscles loose. And then Botox injections. So they can inject kind of the botulinum toxin there to kind of relax those muscles. Shoulder pain, so that's often associated because of, you know, one side that arm isn't working as well, so it tends to hang, and so a complication there is you get joint dislocation, and so from that weakness of the arm just hanging there. And so again, beginning in the stroke, recommended of just kind of completely externally rotating that shoulder for about 30 minutes a day, just to kind of promote that range of motion there. And again, that increased range of motion, working with your therapist to kind of just keep those muscles and that shoulder joint nice and loose. Deep vein thrombosis. So again, most likely it's from decreased mobility. So you're not walking around as much, getting that return of the blood flow to the heart. And so these are mostly in the legs. So a lot of times everybody in the hospital is pretty much sitting more than they usually are, and even after strokes. And so a lot of times we'll do prophylactic medications to prevent that. And so that's a little bit thinning your blood a little bit with heparin or that type of thing. The best treatment, moving, so keeping that blood flow going. Compression stockings, those are to promote kind of that return of the blood flow, but those can also come with skin complications. All right, and stroke recrudescence. This is something we see a lot, but commonly, I say. It's not completely uncommon. The big fancy name is amnesthetic syndrome. And basically what that means is recurrence of previous stroke-like symptoms that had resolved. So it's often triggered by some sort of physiological stress, whether that be electrolyte imbalances, maybe you weren't hydrated enough, you've been under a lot of stress, you haven't been sleeping, and you're just more fatigued, or an infection, sedating medications. Let's say you took maybe an extra Ambien or something to help you sleep. So those can all cause kind of a recurrence of stroke symptoms. And oftentimes, the literature says it's common after about 4 years, but I just want to urge you, it's still important to get it evaluated. So it's better to know that it is not a new stroke than to have a stroke and think it was something no big deal. So if this does happen, always get it evaluated emergently anyway. All right, so resources. This here is the best foundation. This is the best resource, I think, in Kansas City. So you guys are already ahead of the game by being here with the American Stroke Foundation. So, and the Next Step program. Support groups, which Sarah leads. So at KU, we have one the third Wednesday of the month from 6 to 7. It's virtual, or there's in-person option at our Turning Point in Leawood. Turning Point is also through KU, but it's free classes and programs if you like to kind of with a variety of topics. J-Start Clinic, that's our at KU Med, that's working with our students, and you get to work with our PT, OT, and speech therapy students for free. Falling Forward Foundation is out of Lawrence, and it focuses a little bit more on like spinal cord injuries and things like that, but it's also a great resource if you're out towards that location. And then the American Heart and Stroke Association, they have wonderful resources on their website too, that kind of help if you have questions and education. All right, questions. That was a lot of information.